My name is Dennis Keaton. I will be your principal instructor for the next 30 minutes or until you fall asleep. I have given this talk, multiple times, and I really haven't changed the format. So, if you've heard it once, you've probably heard it 3 times. There are a couple big changes, however, and one of those changes impacts Keith. We've got a change in formulation with Dantrolene. So before, when I've given the talk, I talked about the limited supply of Dantrolene that we had in the building. Dantrolene has gone through a new formulation, surprisingly, from the company that sponsored Dr. Rosenberg from M-House, and we have a lot more. So the need to have runners go to the main OR to get more Dantrolene has gone down. It's possible that we'll still have to have runners for Dantrolene specifically, but again, with the amount of Dantrolene that we have in the building now, that goes way, way down. I am required to read the following. You, the participants, must attend the entire educational activity in order to receive 1 CEU. Judy, is this a CEU?
It's a C&E.
C&E.
Certified nurse, it's a nursing thing.
All right, so the sign-in sheet is required to be put in for C&E.
Yep.
Learners have 45 days to complete online evaluation. I know nothing about that. Planners and presenters have declared that they have no conflict of interest and no financial relationships, which would influence the planning of this activity. No one even brought me bagels today, which is my usual honorarium and greatly appreciated. Again, no commercial support has influenced the planning, implementation, or evaluation of the content of this activity. Again, it's an annual requirement. There are other ways to get it rather than looking at my presentation. Alamance has a C or a MH presentation online. You can get it through HealthStream, whatever we're calling it these days. And again, the purpose of this activity is to refresh people's knowledge base of what to do in a malignant hyperthermia crisis. I got interested in this topic many years ago when I was doing a case for Dr. Rosen. Dr. Rosen had a small child. We were doing tonsils for, and with our normal induction technique, which includes a triggering agent for malignant hyperthermia, sevoflurane, initially I wasn't able to intubate the child. It was just stiff. It was stiff. Another word for that is trismus, or masseter spasm. The anesthesiologist that was with me decided that we'd use succinylcholine to help facilitate controlling the airway, another triggering agent. And it didn't help at all. In fact, it got stiffer. Happens sometimes when you use succinylcholine. But in the back of my mind, there was this light that was going off. It says, this could be bad. This could be a harbinger of something bad. Well, I got the patient intubated. We did the procedure, woke the patient up, took him to the recovery room, and when I was giving report to the, again, very experienced recovery room nurse, a lot of SICU experience in the past, I said, you should probably monitor this child for signs of latent MH symptoms. What? What are you talking about? MH here in the recovery room? Because I couldn't remember what the chances were of masseter spasm giving an indication of a full-blown MH crisis. plus 20%. I gave a bedside in-service about what to look for. We made sure that the anesthesiologist was in the loop with this. The child was monitored for more time in second stage of recovery, and nothing came of it. But, as I said earlier, every child that we do, in the main, here, is induced with a triggering agent. We do a mask induction. And as you'll hear from, this is Dr. Rosenberg, rather than the old movie that I had before, he'll talk about the triggering agents. But the bottom line is that every child that we do, with the exception of those children that have IVs in place before we start, are induced with the triggering agent. We'll talk about the incidence of MH in the general population, the differences between child and adult instances, and we'll talk a little bit about the efficacy of testing for patients with suspected MH. I want to turn it over, and thank goodness I was able to get hooked up to the internet down here.
I'm Dr. Henry Rosenberg. I'm an anesthesiologist, and I'm one of the co-founders of the Malignant Hypothermia Association of the United States. Malignant hypothermia is a very uncommon inherited disorder that's characterized by a metabolic emergency that's usually precipitated by inhalation anesthetic agents and the muscle relaxant succinylcholine. So one of the reasons why people get frantic when they have a diagnosis of malignant hypothermia is because they don't see it every day. It's a very unusual occurrence. It may happen once in every 5,000, 10,000, 50,000 anesthetics, and so there are anesthesia providers who will go through most of their career without seeing a case. However, if you ask those people if they have seen a case of malignant hypothermia with a patient under their care, they may say, no, I haven't seen it. But if you ask them if you've been in an operating room or an operating room situation where other people have had an episode of malignant hypothermia and you've had a help in caring for the patient, you'll find far more people have said, yes, they have. Well, the signs of malignant hypothermia are an increase in end-tidal CO2, an increase in heart rate, muscle rigidity, and an increase in body temperature. Those are the actual signs, and there may be laboratory changes that go along with it. And those signs may appear in various orders. So, for example, if succinylcholine is given as part of the anesthetic, muscle rigidity is very often the earliest sign. If it's not, then an increase in heart rate and end-tidal CO2 may be the earliest sign. Now, even though it's said that an increase in body temperature is a late sign of malignant hypothermia, in many cases it's not so late. It comes along fairly quickly after the other signs of malignant hypothermia.
Dana.
When the anesthesia provider is convinced that they are dealing with malignant hypothermia, he or she needs to make the operating room team aware of the disorder, because it's a metabolic emergency where minutes count. The response of the operating room team to the malignant hypothermia crisis is in part a function of how much training has been done in dealing with the crisis. So those teams that have had simulation training in dealing with malignant hypothermia will generally be much more organized and proceed in a more organized way. However, in those teams that are less familiar with the disorder, there's clearly an atmosphere of concern and almost panic at some time in order to get all the equipment and supplies in place and to get additional help. When the diagnosis is made, there is a general feeling that this is a metabolic emergency that requires immediate attention. And there are various tasks that must be accomplished. For example, obtaining dantrolene and bringing it into the operating room, obtaining ice, alerting the laboratory that specimens will be coming, assisting the surgeon with closing the incision, or assisting the surgeon in hastening completion of the operation. So there's a true sense of time factor here in order to get a good result. Dantrolene is truly a life-saving drug in a situation of malignant hypothermia. When the diagnosis is made, there is an immediacy in order to get the dantrolene into the patient. The more rapidly the drug is administered, the more likely there's going to be a satisfactory result. According to the accreditation organizations, it should be available within 5 minutes. Well, the drug may be available within 5 minutes, but the problem is that in order to give a full initial dose of dantrolene, the average adult patient needs to be administered 200 milligrams of dantrolene. So once the solution is injected into the vial, the solution is mixed with the drug. It then has to be drawn up into a syringe. It's generally a 60 ml syringe. That syringe then should be given to a person who is capable of injecting the drug into the intravenous solution, which may be the anesthesiologist or one of the anesthesia providers that are present in the operating room. So multiply that by 10. And so frequently when there is an MH crisis, you have several people just dealing with the dantrolene admixture. So although the solubility of dantrolene has been favorably increased in recent years, nevertheless the admixture process still takes time, and that leads to somewhat of a delay. One of the recent studies from the North American Malignant Hypothermia Registry of MHAUS documented that it takes anywhere from 15 to 60 minutes between the diagnosis of MH and the administration of dantrolene, with an average time of 30 minutes. And that's a function of obtaining the drug, setting it up, and mixing the drug, and then administering it to the patient by the anesthesia provider. And so for every 30-minute delay in administering dantrolene after the diagnosis, the rate of complications could be increased by as many as 1.5 times. The issues in dealing with malignant hypothermia are, first of all, for the entire operating room team to be cognizant of the syndrome and its presentation, to be aware that successful treatment requires a coordinated response, and that people need to be prepared in terms of having rehearsals of dealing with the syndrome. The good news is that when the team is prepared and there is a smooth response, the success in dealing with the syndrome is extremely high, and the morbidity and mortality extremely low. Well, for many years, our hotline experts and those associated with malignant hypothermia have been frustrated by the cumbersome nature of mixing dantrolene. Many practitioners have complained about the need to have 36 vials of the drug available on hand, just in terms of storage, for example. So there has been a need for a preparation that is much more concentrated and soluble and effective. There have actually been a number of attempts to develop dantrolene in a more soluble form, but unfortunately those preparations had other problems associated with it. So clearly, when you're dealing with a syndrome that's time dependent and having to admix multiple vials of the drug is frustrating and can take away from the immediacy of the treatment of malignant hypothermia. In conclusion, anesthesia providers and the OR team need to be aware of the entity of malignant hypothermia. And they need to be aware that the treatment of the syndrome requires an immediate coordinated response. And they also need to be aware that when that response takes place, it can be extremely successful in the treatment of malignant hypothermia with a distinct reduction in adverse effects from the syndrome.
Okay, can we get lights, please?
Hey, Kathy, if any of the doctors show up for the investors meeting, I'm downstairs in the basement, just page me. Okay, thank you.
Okay, let's recap. Malignant hyperthermia is a genetic disorder. There are no good preoperative tests for that problem. The best way that we can assess the risk of MH is a good preoperative evaluation. Coming down to the question when we're talking to the patients, have you or anyone in your family ever had any problems with anesthesia? And ask specifically about problems with getting real hot. Did you die? Did you have an uncle die? Did you have anyone have any problems with anesthesia in the past? Puking is okay. I don't mind about that. Malignant hyperthermia is autosomal dominant. That means that if your father had an MH crisis, a documented MH crisis, the chance of you having MH, 50%. 50%. So, the quibble area is, well, did they really have MH? Did the anesthesia care providers really tell the individual what went on? And that leads us to, how does the patient really know? How can they dial it down to find out if they really are at risk for MH? Well, the incidence of malignant hyperthermia in the United States is 1 in 15,000 in children. Pretty small. In adults, 1 in 50,000. Last time on my notes I had the highway traffic fatality statistics. And it's much more likely that we will die going home in our cars today than having an MH crisis come before us. And again, the severity of the symptoms, the quickness of the onset of the symptoms really depend on the triggering agent. And again, when I was going over to prepare for this, thinking about the case that I described, I thought, shit, I did a SIBO induction, triggering agent, and then we gave SUX, triggering agent, and then realizing that the chance of going into a full-blown crisis with masseter spasm was 20%, I got kind of faint and had to sit down for a little bit. We're doing more patients that have got that specter about them. Maybe I've got MH, maybe my uncle had some problems, but we don't know. The unfortunate thing for getting specific information on whether or not they had MH goes to having a muscle biopsy done. Now, in the United States, there are only 5 centers that do the muscle biopsy. They'll take typically a strip of muscle from the thigh, carefully run it to a lab, and expose it to a mixture of caffeine and an old drug, near and dear to my heart, halothane. When I was in high school, we took frog muscle, hooked it up to a strain gauge, and stimulated it to watch the muscle contract. Well, in essence, that's what they're doing with the thigh muscle test. They're putting it into a apparatus that they're able to expose it to halothane, an old triggering agent, and caffeine to see if it will contract, to have a positive test. So again, that's the gold standard for making the diagnosis. Right now, people are trying to have a blood test drawn. They've been trying to have that blood test become accurate over the past 6 years that I've been aware of. According to M-House on their website, it's still kind of coin flip. They have identified where on a person's gene the trigger or the abnormal gene process is, but it's not real accurate. They can find with their evaluation of the gene whether or not that particular gene is abnormal, but it doesn't mean in the real world whether or not that individual is going to have a crisis. So, although non-invasive, if you call someone drawing blood from you non-invasive, procedures are in the offing, not good enough to really make a good decision on yet. The nice thing in our area is that one of those 5 testing centers is Wake Forest Baptist Hospital just down the road. The bad news is insurance doesn't pay for it. And having a muscle biopsy under anesthesia is expensive. So it really comes down to how valid or how real a chance them having a life-threatening crisis is. There are genetic counselors that can be found through the Malignant Hyperthermia Association, and every testing center has them. So if we had someone that we were considering to have evaluation for MH, going to Baptist, having the genetic counselor talk with them would probably be a good first step. But again, we're going to make sure that we have the anesthesiologist that is overseeing your evaluations concur on that, because insurance is not going to pay for the genetic counselor.
Dennis, I have a question.
Yes, ma'am.
When you were talking about the muscle rigidness, was that cluing you in then?
That was, again, the light was going on. Again, it had been a long time since I had thought about it. The relationship between masseter muscle spasm and MH, but it was back there somewhere. All I knew during the case was, this is bad. This could be real bad. Something's...
Question on that. If that was in the back of your mind, were you trying to give sucks to see if it was going to go into
No,
that?
it was...
That's
The suctional choline was the second one,
treatment
because we
route.
couldn't open them up
Okay.
with the SIVO.
Okay.
So again, the anesthesiologist that was there said, "Oh, let's give him some sucks." Didn't help.
Okay.
I'm actually pretty proud of myself for not knocking a tooth out, for getting that tube in. I'm kind of surprised that Dr. Rosen was able to ratchet the mouth open to get the tonsils out, but that happened.
And is it just in the masseter or is it muscle? Because I know suction gives you muscle rigidness all over, correct?
Correct. Some of the signs that we'll see on the table or in the recovery room, if it is a late onset, tachypnea, they're going to breathe fast. Generalized muscle rigidity. Unexplained tachycardia. The area of action of the MH crisis is at the striated muscle level. You can all remember looking at your physiology texts to look at the representation of striated muscles and you'd see bands like this. The MH crisis releases calcium. So the muscles are going back and forth, 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 back and forth. That's creating the rigidity. With that activity, it's creating a lot of oxygen use and a lot of carbon dioxide production. So on the anesthesia machine, on our monitors, we'll see the end-tidal carbon dioxide go up, along with the tachycardia. In the old days, before we had EtCO2 monitoring, I trained in those days, we'd have to look at the soda line. Because the increase of carbon dioxide production was dramatic, our carbon dioxide absorber would change colors real fast. Because it's an exothermic reaction, you'd put your hand on the soda lime absorber and it would get hot because of the reaction of the carbon dioxide and the soda lime. So, tachycardia, EtCO2 going up, muscle rigidity. After those things, generally, the temperature goes up. Now, as Dr. Rosenberg said, increase in temperature is a late sign, but maybe not so late. It could be going up pretty fast. Diane Joyce talks about a case that she was involved with here in this building many years ago with a nurse anesthetist that's no longer working here that had a crisis, and the only thing that clued her in was looking at his monitor to see the temperature was 104. So, when I was in training, Dantrolene was just starting to be used clinically. Prior to the use of Dantrolene, if an MH crisis occurred, the chance of dying was 8 out of 10. 8 out of 10. The things that we had to treat it were symptomatic only. I worked in an operating room that had a camp bathtub, a canvas bathtub that we were going to take into the operating room, put the patient in while they're still hooked up to the ventilation apparatus, and pour ice on them. Also, we were going to put a Foley catheter in and do a bladder lavage with iced saline. We were going to put nasogastric tubes down and try to get the temperature down with iced saline in the stomach. Well, again, doing those things, just treating symptomatically, 8 people out of 10 died. What killed them in the operating room were cardiac dysrhythmias. Muscles going back and forth, back and forth, back and forth, back and forth, back and forth. Muscle damage, muscle death. Potassium is a major component of intracellular muscle. Potassium goes up, heart doesn't like it, PVCs, ventricular tachycardia, in nomine Patri et Filii et Spiritus Sancti, Amen. If they got them through the initial crisis in the operating room before Dantrolene, what killed them was renal failure. Like a patient that has been in an automobile accident, rhabdomyolysis releases myoglobin into the circulating system, goes through the kidneys, plugs up the kidneys, causes renal failure. So, in our treatment, in our recovery room, if we had a crisis here, before we would get them in our ICU, we'd put a Foley in, we'd check for urine output, we'd give them Lasix, we'd make sure that we didn't see blood in the urine. In the handout that I put out at the table, this is one of the new recommendations from M-House that I thought was pretty unusual, although it made a lot of sense. If we had a MH susceptible patient and we did a non-triggering technique and we do them with great frequency here now. They follow the normal recovery protocol, but the recommendation from M-House is just to cover your bases, you should probably have them piss in a bottle and do a hema check on it to make sure that there's no blood in the urine. And if that dipstick was positive, probably needed to send that urine sample to the lab to see if there are any RBCs in the urine, not to differentiate it between frank blood and myoglobin. I thought, that's actually a pretty cheap thing to do. Might be pretty smart to do. I suspect it would be something that we'd have to make sure that the anesthesiologist was on board with, but it should be relatively cheap. I already talked about Keith with our Ryanodex, our new formulation of Dantrolene. We've got 3 vials here. Again, one of the vials is 250 milligrams. The initial dose of treating an MH crisis is 2.5 milligrams per K. So one vial is, if we're looking dry weight for me, enough to treat me with the initial dose. In the past, we didn't have a lot of the old style Dantrolene vials because it's expensive. It's really expensive. So there was a plan in place to share Dantrolene between us and the big house. With 3 vials of the Ryanodex here in place, that goes way, way down. I used to say that the first thing we should do in an MH crisis is call for help, call the anesthesiologist, confirm the diagnosis of MH, and get someone to bring the MH box into the room. Well, our Dantrolene is in the anesthesia Pyxis now. So the first step after we've got the anesthesiologist in the room is to go to the anesthesia workroom, open the Pyxis up for the Dantrolene there.
How it's labeled? Is it labeled Dantrolene and Pyxis?
If you put in Ryanodex or Dantrolene, it'll come up. DANR.
It might be good to put a label on that Pyxis. Just have a brain.
Well, I checked this morning, and I checked that we've got 3 vials, and if you put in DAN, the only thing that comes up is Dantrolene. Now, the Ryanodex, again, Dantrolene, is reconstituted with 5 cc's of sterile water. One of the selling points of the company, of the old formulation versus this, is it goes into solution real fast. It goes into solution with a small amount of fluid. It's easier to reconstitute, easier to administer. Those are all good things. The company that makes Ryanodex did a study, and their contention is to get an equivalent dose of old-style Dantrolene in solution, ready to administer, takes 10 minutes. So, if the thing that saves the patient's life is the administration of Dantrolene, getting it on board quickly is a good thing. The things that we have in this box now are the things that we would do for second level care. We've got a Foley catheter in here. We've got lab slips in here, although we haven't got lab tubes. We've got nasogastric tubes here, and we've got catheters to do an arterial stick. In this building, we do not have the cassettes on our iStats to do blood gases. Tammy knows that we've got to call respiratory therapy right away. Now that number is on the top of this box. Call RT. We can do basic electrolytes, we're gonna look for potassium. But the thing that we are going to have here quickly from outside of this building is RT to do a blood gas determination for us. The labs for CK, well, that's going to be later on down the line. We're going to want to do CK levels to determine the severity of the rhabdomyolysis that is ongoing, to help determine whether or not we need to get a dialysis catheter in place right away to help save their kidneys. That's going to happen when they get to ICU. So, yes ma'am,
Where's the water to be put down? Does it come with it?
they're in the Pyxis, and we've got some sterile water for injection in our anesthesia Pyxis too.
So we have to get that too. When we go in.
We've got some, we've got enough sterile water for injection in the anesthesia Pyxis to do an initial reconstitution.
Right, so when we get the Dantrolene, we also have to get the water out of the Pyxis.
Sterile water for injection.
Okay.
Is
What's
with
the
the
sterile
Dantrolene
reconstitution?
water?
No,
What's the reconstitution of?
The reconstitution is 5 cc's per vial. So you've got 50 milligrams of Dantrolene per cc. More concentrated, easier to give.
You know, you might need to at least put a note in there with Dantrolene saying get water too. 'Cause I don't know if I remember.
Why can't you
why
rub it
can't
down
you?
together?
Yeah.
Well, I didn't put it together in the Pyxis, and I think it's a pharmacy thing. But, again, in our carts,
You just have enough sterile water.
we've got enough sterile water. Well, again, if you have to reconstitute any medication, is it just that you've got sterile water for injection? I mean, don't you have,
We use saline.
We have saline in our Pyxis.
We
but you don't
saline.
have sterile water for
I
injection?
don't
No,
know.
we do not.
don't dilute, I can't think of anything we would reconstitute.
We always use saline. That's why I asked, because we don't have water that I know of. Not injectable water.
Again, I've done both for a long, long time, so.
I
You know,
think
you
there
know,
is water in the Pyxis.
Is there water in it?
Sodium
For what?
I think so. No, that's saline. I think there's sterile water.
Pink top, sterile water.
It's got a pink top on it.
Yeah.
Well, I have to look at that. But I won't remember it. I'm just telling you,
Well, again, because of the reconstitution, and I know that we've got sterile water for injection on our Pyxis,
In the room.
in the room, that,
In our Pyxis, it's in the Pyxis. It's an anesthesia Pyxis.
in the room Pyxis.
So enough for the first dose, and then we can go back again.
All right, so, we've identified it, we've called for help, we've asked someone to go to the anesthesia cart to get Pyxis. I've called Tammy to call RT in place, and we're hoping that the administration will take care of the problems, get them stable enough to transport out. Now, the maximum dose of Dantrolene in a 24-hour period is 10 milligrams per K. The recommendation of administration of that, once they get to ICU, is 1 milligram per K every 4 to 6 hours, up to a total dose of 10 milligrams per K. Okay, but that would be in ICU. Again, we'd call for help and get there, but out of here. All right, I've talked about testing, I've talked about reconstitution. For the anesthesia care providers, we are talking about our stuff all the time. In the old days, when we'd prepare for a patient that was MH likely, it would be a big deal. I've worked in places that had a clean machine, that had no vaporizers on them, never had vaporizers on them, so they would have no chance of exposing the patient to a triggering agent. That's pretty expensive. It's nice if you can afford it, but not needed. The filters that have come out in these past several years are very, very effective. The product manufacturer guarantees the effectiveness of the filters for 90 minutes. An outside testing agency looked at them, and they stopped testing after 6 hours with no change, with no decrease in the effectiveness of filtration. So the question came, well, the company says that they're only good for 90 minutes, should I change them out? If you ask the lawyers, the answer probably is yes. But if you run out and you haven't got any more, are you really going to increase the patient's risk by having it for 2 hours instead of 90 minutes? Probably not. But again, that's a question for the lawyers, not us. The question arises, should we do MH positive patients in outpatient surgery? We've done it before. We have patients that have been in that gray area. Well, my uncle had blah, 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 and maybe he had this, but no muscle biopsy to have a definitive diagnosis. We've got trigger-free techniques available today. When I was in training, we didn't have them. So, again, my pucker factor was a lot higher then. For a child, the question comes up, and came up a couple months ago over at North Elam Medical Plaza. Dennis, we've got a couple kids that are on the surgery schedule, and they were okayed by Dr. Jackson, Kyle Jackson, for dental work. And there's a possible MH tie-up. What should we do? Again, with kids, no one likes to start an IV on a screaming kid. We haven't got papoose boards here, but there are ways that we can stun them. Nitrous oxide is okay to give to an MH susceptible patient. So you can give them laughing gas. You can stun them with ketamine. Get the IV started, and then turn over to a non-triggering technique. So it can be done. Not as easy as what we do for our tonsils or our PE tubes, but it can be done. And the question of whether it should be done in outpatient surgery, again, goes to the attending anesthesiologist at the time. Again, we can do it safely here. Should we do it safely here? Plus or minus. I've anesthetized the same guy a couple times here with a non-triggering technique. It was a miserable experience, but he did okay. Miserable for me. We've had other patients here that, again, had that nebulous cloud over their head, did a non-triggering technique. Other providers here have done non-triggering techniques, did fine without any problems. So we've demonstrated that we can do it safely here. And again, take them, if we have it, stabilize them, get them out of my building and to the ICU. If we have a non-triggering technique, regular recovery protocol, and maybe think about doing a urine dipstick. Again, that's the new recommendation from in-house. Questions?
Remind me, Dennis, what Dantrolene actually does. How does it work?
Again, the place of activity is at the striated muscle. Back and forth, 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 back and forth. Dantrolene stops that. If we gave Dantrolene, it would cause a flaccidity. It doesn't work at the myoneural junction like most of our muscle relaxants. It works directly at the muscles. So if we give Dantrolene, the chances are they're gonna need a blower. They're gonna need to have a ventilator. So if we give it, they can't stay here anyway because we haven't got a ventilator in the building. But it works at calcium channels at the striated muscles. Anything else? Yes, ma'am.
This is more curious than anything. When you had the kid with the jaw, the masseter, and you said he ratcheted his jaw open, I mean,
We do that all
did
the,
you break it
no.
by accident if they're locked up like that? And they're kids? I don't know, I was just thinking.
Again, a lot of strength and determination. But again, I'm surprised that he was able to get in with that small space, get his instruments on the tonsils and get them out.
But I guess worst case scenario, you
Oh, I wasn't
but that would
saying
take-
like break
take
it
some
open,
doing,
but
yeah.
the risk of, like, if
Yeah.
you do it, you could break their jaw back, not meaning to, I guess.
Nah. Probably not. Probably tear the muscle, but not break the jaw.
Okay.
But you said that wasn't an MH.
It was not.
So
It
what
was not.
could have
Again,
caused that muscle rigidity?
Don't know.
we're seeing?
I've had one case with the other Dr. Miller that all of a sudden, middle of the case, the pediatric dentist puts the clamp on for a rubber dam, and the heart rate goes from 102 to 162. Boom, just like that. Dr. Smith was my attending. He came in, we were both scratching our heads. Wasn't light anesthesia, wasn't pain. He laughed at our beta blocker. But we didn't see other signs to tell us that it was an MH crisis. It was just one of those, damn, something's happening, I don't know what it is. What should we do next? But it didn't get to the point where we thought we needed to call respiratory therapy to do a blood gas. Carbon dioxide levels were fine. No problems with generalized muscle rigidity. Just an unexplained tachycardia. That was boom, like that. So sometimes we've got unexpected responses and we saw, I don't know what's going on. Let's get this airplane on the ground now. And then it's, I don't know what happened, but we walked away. Anything else?
Where is the refrigerated saline now?
In the anesthesia workroom.
Okay.
Okay, when you have the bug juice,
Mhm.
we've got refrigerated saline there.
Okay.
Now, the question is for me, I don't know how to get into that locked one. I've tried it in the past unsuccessfully.
There's a sign above.
The instructions are above the machine, how to get in it.
Oh,
You're
okay.
doing an inventory count.
Maybe we should put a hammer there in case
Yeah.
of emergency.
Inventory count.
All right. Any questions at all?
Thank you.